This is Outcomes, a show about uncovering the hundreds of micro-innovations that help make Australia's healthcare system one of the best in the world. On the show, you'll meet the doers, the Australian clinicians, care workers and healthcare professionals driving the micro changes we seek to showcase. Theirs are the stories we're here to tell. I'm your host, Will Egan, and I'm the CEO of Aussie Education. I'm really passionate about improving the health and prosperity of the people in my community. I believe Australia does have a great health system, and every conversation we have on this show highlights why. Today, I'm joined by Rory Tanner. Rory is a peri-anesthesia clinical nurse specialist and a clinical nurse educator. He is also the Managing Director of Life-Saving Education. We explore the world of day surgery, starting with a blow-by-blow account of an anaphylactic event. The fascinating thing about this example is the fact that the quality initiative his team relied upon had been implemented only a few weeks prior. It's a strong example of the impact we can have on improving outcomes right across our healthcare system because it really highlights the benefit of spending time in advance planning for the unexpected. This episode is fast-paced and I think you're going to love it. Let's begin. Well, welcome to the show, Rory.
Hey guys, it's great to be here.
Fantastic. Rory, I'd love to kick it off by asking you to share a little bit about your background with the audience.
Yeah, no worries. So my name's Rory and I'm a registered nurse. My background, originally started way back straight after school as a professional beach lifeguard in aquatic rescue. But very soon into that journey, I discovered the world of education and inspiring others to sort of be their best and discover new skill development and become confident and competent with what they're doing. And as I entered nursing, the same sort of theme progressed through. So I spent sort of 10 years being a registered nurse, and across those times I've spent a lot of time in emergency and perioperative care, mainly peri-anesthesia. And my focus now is sort of anaesthetic nursing and running the Aussie Nurse Educator online, and also running my training business, which is Life-Saving Education. So my clinical world and the love of all of patient care sort of combines with the education world of everything that I do, more now in the clinical setting rather than the aquatic rescue setting.
That's fantastic. And am I right in understanding that you've also had a stint as a life-saving emergency responder in a helicopter?
Yeah, well, I've done a bit of training in that, but my main sort of aquatic rescue stuff was on the beach as a lifeguard. Did a tiny bit in pools as lifeguard and stuff like that. I'm a trained paramedic, but not registered. And I don't currently work with New South Wales Ambulance or anything like that. So I'm not on any helicopter in a clinical capacity. But it's interesting you say that because in my training business with Life-Saving Education, I do train a few different medical and rescue-based services. And one of them I did as recently as Friday, which was only just for the weekend that just passed. And they had me in a helicopter and we were flying around doing some simulated, sort of medical cross-rescue sort of situations for their training, which was fantastic. So yeah, it's something that I do love doing, getting outside and combining it all together, and especially if you get the chance to do that in helicopter. But I'm not currently working in a helicopter now.
Fair enough. Wow, that sounds very exhilarating. And tell us a little bit about Aussie Nurse Educator. I've come across that website quite a lot. I know Ausmed's featured on it, but also it's very popular on Instagram. What do you do there?
Yeah, so I guess the Aussie Nurse Educator was something that come about a number of years ago now as an idea on the back of what I do with Life-Saving Education, which was traditionally more, community-based training and training for businesses within the community setting before getting to sort of health and medical-based stuff. And when I sort of went through the years of being a registered nurse and became a clinical nurse specialist and then went into clinical nurse education, I found a lot of hospital avenues of getting education out to staff, friends, and even building a community or sense of community around your education, or even just networking between people in your sort of clinical area. It was very restricted in the hospitals that I was based in, but also just generally in Australia. That sort of led to me wanting to combine education and all of those things I just mentioned together, along with being able to do it for myself. And I thought that if you could have your own website, that you could do, all of that by social media, but also have an opportunity to build that community behind a following, and also have interested people in your areas of content, and also have this sort of engagement with people outside of your local area and inspire others within all of those things would be pretty cool. And the Aussie Nurse Educator was born at the start of 2021, and it was really just me sharing my interests and a tiny bit about my journey. And of course, getting started there brought all the fun things in getting on the internet, like imposter syndrome and feeling like, why am I posting this, and all those sorts of things. But to tell you the truth, like, the Aussie Nurse Educator has been one of the most interesting journeys I have embarked on, because I have been able to do many different things such as this and other types of podcasts, but also other physical events, some experiences that have really impacted my professional journey, but also been able to impact other people on a scale that I've never really imagined. And throughout everything I've done, I've always just wanted to be able to help other people. And I think helping patients is very rewarding, but doing that is sort of one-to-one, and you only sort of influence one at a time. But with education, you can actually influence many clinicians and many people, and then many patients at a time, which I think is very powerful. And that's something that I've been able to see and experience with the Aussie Nurse Educator.
That's a fantastic story around why what you're doing with the Aussie Nurse Educator is so important. I can definitely relate to the imposter syndrome, feel that on a regular basis. But, the impact that the web can facilitate for people like yourself, initiatives like the Aussie Nurse Educator who do want to help and use the power of education to empower people and support them, is quite profound. What I might do is segue from there and ask you to take our listeners into your world in day surgery. What's that like? Help us step into that world, out of the car, off the bus, or wherever we are when we're listening to this, and take us into what it's like in a day surgery setting.
Yeah, so I'm not currently working in day surgery this year on this day at the moment, but as you know, and for the listeners, I spent a number of years doing so, and I do pop my head in every now and then, literally every month, and do some work in day surgery settings. And I guess I didn't realize how much I loved it until I left. So my world in these settings started as an anaesthetic nurse, moving from a bigger private hospital and doing a bunch of different stuff before getting to a day surgery environment. For our listeners, for a bit of context, you can be sometimes doing very simple procedures with very simple anaesthetics, if not any anaesthesia at all, but you're doing procedures. And then you've got procedures that turn into surgical procedures that involve quite in-depth anaesthesia. And this is all provided in an environment that has a 23-hour, 59-minute license to hold patients. So most patients are in and out in a couple of hours or, in a day sort of thing. But some patients do stay overnight for that 23-hour period. And these patients do sometimes have potential to have complications and deteriorate, although that's not what happens regularly. It does have the potential to happen. So, obviously training and staff competence and everything goes a long way, but also with the care of these patients, it's quite a small environment sometimes that these services operate in, and you've got a high turnover of patients and people, and then a high amount of staff that are doing their jobs throughout the day to move out throughout these areas. So there's a lot of different problems that I guess that are exacerbated that you don't maybe notice in bigger hospitals, or sometimes are not so much as the focus, that become a bit more at the forefront in a day surgery environment.
And what would be some of the procedures that, at least when you started your career in day surgery, were commonplace? And I'm curious if you could comment on whether you're seeing more procedures become a day procedure than what has been the case in the past.
Yeah, definitely. So sometimes it's a balance between the anaesthetic team, the surgery team, and the patient as to what is best for the patient to facilitate that surgery. And I've seen a lot of surgeons even move towards, having their patients more, awake per se, but you're not awake, obviously, you're sedated. And there's other ways that anaesthetics has progressed over the years. So you've had the introduction of spinal anaesthetics, which is sort of like the traditional epidural that's one shot that doesn't last that long, that's fairly safe. And then you've got regional anaesthesia, which has totally changed the whole way that we do anaesthetics. It's when you can put local anaesthetic around major nerve bundles and sort of block that area for the surgery. So you can do that on the limbs very easily, obviously for knee surgery, ankle surgery, hand surgery, all that sort of stuff it's very easy to do. But you can also do blocks around, people's ears and stuff for complex skin surgery and stuff. So you've seen a time where local anesthetics have been around for a long time, but local anesthetics and general anesthetics were sort of the mainstays for years. And now you've got a situation where there's a lot of other styles that enable patients to be processed more safely in a quicker fashion so they don't have a recovery time in terms of they don't have hangover from the medications because they're not having complex, massive GAs for simple procedures. And the best example I can think of here is as little as maybe 20 years ago, cataract surgery was being done sort of under general anaesthetic, and someone would stay in hospital for 1 to 3 days based on their situation. Where in today's world, a lot of cataracts are done under a regional block and sedation, and the patient is well tolerating of that, and they wake up with full function of their eye like straight away. I guess to finally answer your question, I am seeing a lot more different specialties come into day surgery settings, seeing a lot more volume of patients come through due to the level of efficiency that we've been able to get to in these places.
The level of experience and genuine kind of understanding that you have of this space is quite profound, and it's certainly coming through in the way that you're answering the questions, Rory. So please keep it up for our listeners. It's very fascinating. I might use your comment there towards the end to kind of prompt you with perhaps the first example that you'd like to give around ways that these types of day surgery or hospitals services have been able to improve that efficiency or the outcomes in particular for patients. Tell us a little bit about the emergency equipment availability kind of example that you have.
Yeah. So I guess the first example I'll share with you guys is a specific one around an anaphylaxis box, but I guess more broadly around emergency equipment and the initiative of focusing on that, but then implementing it in a small perioperative setting, so a day surgery environment. With these things, what my experience has been is that, in the bigger hospitals, people expect it to happen and there's a bit more focus around having these things maybe there and in place, but that some of the small places, it's like, oh, but this might not ever happen, or it's just over there, or it's just in this, or, here we just do that, and all those sorts of things. But at the end of the day, when you have staff that come and go, or staff that only work certain days, or they work across different facilities, it's great to have sort of a standard sort of process or way of doing things. And I guess this is where your clinical expertise comes on board.
Just to step back a second, Rory, the word things that you're using here, is this things like EpiPens or what?
Being a peri-anesthesia environment or a perioperative environment broadly, and then a day surgery hospital, we have to be prepared for anything that might happen because of what we're doing for our patients. So one of those things is definitely anaphylaxis. And if you look outside of anaphylaxis, there's a lot of anesthetic and perioperative emergencies that we have to be ready for. And over the years, they have grown in terms of what we need to focus on, and they've got guidelines and resources around that are provided to us by professional groups within sort of anaphylaxis and or perioperative or peri-anesthesia care. So these things that I'm referring to, various aspects of this as it sort of folds out. So I guess the total background is that we needed to have something, and I wasn't that sort of satisfied that it was a consistent system like I've experienced in other places, and also what I'm aware of because of my clinical specialty and training and the resources that are available to us. And I guess this came about in a time in my career when these formalised resources only just came and became sort of a part of clinicians' resources to refer to. So they were always doing things through great committed clinicians being aware of things and saying we should have this together in a spot, and stuff like that. And funnily enough, here comes this idea of anaphylaxis box, and it's not something that I developed. It's something that is widely researched, and it's written about in all of those professional guidelines and documents I just mentioned before. And there's also specific clinical action cards and cognitive aids for us to use to also facilitate the response as it's happening. So the idea is to have all of these things in a box to make it quickly available in that emergency.
So how did this problem come about? How did you know this was an issue in this specific setting? And was there an event or an incident that triggered it to kind of come up on your radar?
Yeah, so part of all the training outside of anaesthesia is making sure emergency equipment is available. and there and ready and stuff. And then I get to anaesthetics and it's the same thing. So that's been part of my training since, day dot, is make sure your emergency stuff's there. And I've worked in jobs before where you do 98% routine, 2%, oh crap sort of things. And I've worked in jobs too where there's a lot more sort of crappier moments that you've got to be prepared for. And it doesn't matter which one. There's good systems and practices that promote, us clinicians to work well during those moments. So I guess I first moved to this day surgery environment and I didn't see this sort of setup. And when I asked a few people, there wasn't too many people that knew about it. So I saw this sort of breakdown in that there was no sort of system, there was no awareness. And then I wanted to make our patients as safe as possible by having the clinicians as confident as possible with a process that was defined, laid out, and that they were trained and everyone knew. So this process, in the end, the exec that sat downstairs knew about where this box was and all of that sort of stuff. That's how well the process sort of was in the end. And that's sort of what I'm talking about. If you sit behind a desk or you work in a theatre or you're an admin up the front, you should sort of somewhat be aware of this sort of stuff. Yeah.
Absolutely. I think all risk management really stems from your ability to identify potential errors and then have a plan in advance of how you might act or behave or handle that situation.
Yeah.
I think it's effectively your ability to expect the unexpected and trying to make those decisions for the first time in the middle of the crisis. Invariably, people won't have the presence of mind to make a good decision.
Yeah.
And in a healthcare setting, that might lead to quite a bad outcome for a consumer. So thinking well ahead and having people prepared absolutely means that when that crisis arrives, everyone knows what to do. And a lot of those things that would otherwise be decisions just become almost working like clockwork so that whatever brain capacity is available can actually be allocated to the nuance of the situation and not the common elements, such as responding to an anaphylactic event, perhaps. Is that a fair summary?
Yeah, definitely. And I've got a real practical clinical example of this.
Tell us a bit about that.
As it is, we need to have emergency equipment available. There is now resources around this specific anaphylaxis box and other emergency stuff within anaesthetics. And you've got me who comes along, passionate clinician, and wants that in place and then wants the humans to be able to be focused on their day-to-day work, but also empowered and, well functioning in that event that it does happen. And this is an environment where it's the 98-2. So you should be doing your day-to-day work 98% of the time, but the 2% of, oh my God, this is happening, you want this stuff to be in place. So I worked hard, popped these things in place. And after they were in place, I had an ICU nurse who transitioned into anaesthetics. And this ICU nurse, very competent in her job in ICU. And the issue is you're transitioning to theatre. So it's a different way of thinking, and sometimes there's different cares. So a good example of that is anaphylaxis. So this resources and the documentation behind anaphylaxis specifically allows anaesthetists and peri-anesthesia nurses to provide slightly different care for the patient initially when they're in the environment under the direct care of the anaesthetist. And this is where this box and this training comes about. And I was spending time with this nurse who was new to this environment, talking about this stuff. And we have these cognitive aids in there. And I said to her, in the event that we have an emergency, you're the anaesthetic nurse, you're transitioning to anaesthetics, your role might be to read these cards. And when you're reading these cards, you just need to confidently read the cards from top to bottom, exactly what they say, and effectively communicate it out to the team and give us a chance to respond so we can work through the cards and work through each card till we get to wherever we get to in this clinical care of the patient. And we talked about that. And then it's one of those situations that you can just see in slow motion play out now. The next week, she's caring for a patient and under general anaesthetic, which was only induced like 2-3 minutes prior to me arriving in the room, this patient went into a situation where they were showing signs of anaphylaxis. And for our listeners, when someone's under general anaesthetic, we don't have any symptoms. The patient can't tell us how they feel. And we can't ask them anything to get anything out of them. So there's no assessment. We can only go by the history we ask them, and we can only go by what we're literally seeing in front of us. So the anaesthetist recognises something, presses the button, and I was actually downstairs in the exec area of this hospital at the time, but they've got the alarms that pop up, and I could see it was in a theatre. one of my new staff members in my area. So I'm moving straight up there to support her. And this situation plays out. So this anaesthetist was quite worried. He looks at me knowing that I am a specialist and quite passionate about my clinical area, but also have my pre-hospital care training and stuff. And he starts running the story by me. And one of the nurses had grabbed this anaphylaxis box, pushed it into the room, and here we are grabbing these cognitive aids, and I'm handing them to this new nurse from ICU, and she's starting to read them from top to bottom. And halfway through reading the first page, as we're working through it, the anaesthetist gets a bit worried and he snaps and he says, "You're reading the wrong part of the page." And I look at her and she looks at me, and I said, "It's okay, just keep reading the cards, sort of remember what I said." And she keeps reading the cards, and I looked at him and I said, "It's okay." She's reading the cards. And as little as a minute later, we're giving a life-saving dose of adrenaline, intravenously, which is what we're able to do in anesthesia with patients under general anesthetic. And we reversed what we were seeing clinically and what was happening to the patient and made her well again. So, this situation, played out, and I saw it from all aspects, from sort of the passionate clinician, but also the educator, but also the person working with the VMOs, providing services in an isolated setting without sort of intensive care backup and stuff like that. So I loved, sort of being part of this project. And, I'm obviously very passionate about anesthetics. So, it's only natural that I go through and sort of have that same passion for all of these things. And anaphylaxis has been something since aquatic rescue right through to nursing paramedics and right through the operating theatre that I've been interested in from both the patient side and us clinician side. So, you can see through that example that these boxes just had such an impact on everything.
And do you partner these types of initiatives alongside education?
Yeah, definitely.
Tell us a little bit about that.
So I've made a bunch of anaphylactic-based education before. My second example today is where I was a perioperative clinical nurse educator, and, you're sort of in an environment that is primarily providing a faster pace, highly specialised surgical care of patients that, they spend a lot of time doing that clinical care. So their downtime is resting and ensuring the hospital's ready to go again, sort of thing, for the next piece of work. So when you look at the rest of what is encompassed in the nurse's role, which is like professional development and, mandatory training, all the education and support to do the clinical work that we do, and, all the different aspects of what we do as nurses, I focused on that educational area, being the clinical nurse educator. And the first thing that I obviously noticed is that there was no sort of formalised access or option for staff education outside of the mandatory education offered each year. This was an opportunity that I sort of saw to be able to improve in this hospital, and I did a bit of an informal look around in terms of like what had been offered before, over history at the hospital, being a new sort of person in that role, but also doing some informal surveys with staff and seeing what they sort of thought about it.
What type of questions did you ask in that survey, if you can remember?
So the questions were based around, how did they feel education was in their work environments, and do they feel like they had access and options available and provided to them, or did they feel it was solely up to them? And, I guess the theme across this survey was exactly the same across every hospital service. It is usually something that is reactively put together that's just clunky or not user effective and useful for them. That's a bit of a shame, really. And, the questions was around their satisfaction, but what do they feel that would be great for them? Because, in this environment, you can't put on 3 in-services throughout the day, or even 1, because one of the staff going to do that. Because in these environments, you might work a 10.5-hour shift, but in that 10.5 hours, you might have a list that goes all day, or 2 lists that goes for 2 sessions across the day, so an AM and a PM list. You will only get that literal 30 or so minutes to have your lunch break, and that is it. Like that is literally it. And it's the VMOs that often will stop and sort of sit with you and have that lunch, so the nurses can have that break. And in a lot of these private hospitals that are day hospitals, they offer bigger shifts to nurses, so they don't have 2 shifts of nurses and all of those types of things. So there's a lot of different aspects in the nursing role that pop up as a challenge. And I was trying to feel what the nurses thought worked for them in an environment they had been in for a while. What I focused on all of that was that I wanted to sort of take the initiative on of getting a learning management system available to staff with some courses and education focused towards them, but also focused from sort of a mandatory compliance perspective, but also giving them an opportunity to look at things within their specialised area of interest or go a bit broadly and contribute to their own PD. And I was looking for them to not only have that engagement for themselves, but for the hospital and for their patients. And when you look at providing a learning management system, it's something that they can not only access all the time, but it gives them that wider range of resources, but then also creates this sense of a point where they can start talking, and then that talking can turn into really powerful change within their own work practices or their networking within the workplace, outside of the workplace, which engages them further with their work and conferences and blah blah blah. We could talk forever about it.
Absolutely.
But this effect that went through, I guess, was seen throughout the process, but towards the end. And I guess, that achievement at the end with implementing this learning management system gave this significant engagement towards professional development and fostering this culture of continuous learning. So we saw people going to more conferences, and we saw staff talking about it on the floor, and we saw compliances with professional standards and awareness of those things, go up. And, because of all of that, we saw, sort of more engagement in patient care and enhancement and all of that. The experience that I've witnessed saw, 10 different areas of benefits where you might only have objective data for 2 or 3 things. And I think that within itself is very powerful.
Rory, so did you see, by offering an ongoing education solution alongside the mandatory training and then encouraging staff to take that up, you saw a significant increase in the amount of learning that was going on that was self-directed, so presumably happening outside of work hours, happening for the sake of a professional interest. Is that the case?
Yeah, definitely. So the product we implemented, and the one that I was highly focusing on the whole time, was a product called AusMed. And this
fantastic.
Yeah.
I was worried to ask what it actually was, but I'm glad to hear it was AusMed.
Yeah, it was AusMed. And as I said, there was a lot of challenges along that pathway, but once we did it, just instantly off having an access to a learning library with all of these different aspects and avenues and categories of, different types of education and patient care and different clinical environments and stuff like that, and then different styles of education delivery, really promoted excitement amongst the staff. And then if you couple that with sort of a multifaceted learning management system that offers CPD monitoring and reporting, and then, what we saw benefit when I was in this education role as a manager, as well as the management behind the scenes, so the back-end educator and management logins that we could use to report and allocate and to help staff, keep engaged and do their work, but also communicate with staff through using email networking and working alongside AusMed with making sure it was the best experience that it could be.
Thank you, Rory. I better get you to stop talking about AusMed in case people think this is a big ad or a setup for AusMed, but I promise our listeners it absolutely isn't.
Just to be clear for the listeners, I am a lover of the AusMed product and found it through just traditional research and doing a project in education in being a clinical nurse educator, and I'm not financially benefiting from anything I say or do with AusMed in this aspect of work.
I appreciate the disclosure.
So that's the disclosure for that. And I was definitely not asked to say anything about that. And I'm also a paid subscriber of the product. So.
Oh, there you go. There you go. Thank you, Rory. I was going to ask you the toughest question that I get asked, but I think you actually answered it. And that question is, how does education improve care? And I think what you've said there is that it sits alongside other initiatives. Maybe it's a standalone thing, but in the case of the anaphylaxis example, by having education support the physical anaphylaxis box or emergency box, the staff members feel more prepared. They obviously are more informed and better equipped to actually act in that moment as well. So we often see education as much more of an adjacent or a conjunctive exercise alongside those types of initiatives. I won't ask you to respond to that, and maybe I'll move us along to your final example, which is around enhancing patient-centered care. Obviously, this show, being titled Outcomes, is absolutely focused on that. And, I often mention at the start of the show that outcomes in Australia's healthcare system has the highest rate of health outcomes in the world, number one. I think the example you're about to give us now, it really is a testament as to why. Take us there.
I think something that we've only just started focusing on the last few years, and that's getting feedback in all avenues of what we do. So feedback from your nurses, feedback from your doctors, and feedback from the patients, and absolutely everyone in between, that actually gives you a comprehensive picture of, the problem, and maybe refocuses from what's identified to what might be the actual problem with what's happening. We've recognised that, these post-op calls that we've been making to patients have been getting mixed feedback, and that's from all patients. And in a specific population of patients, they come to see us very often. So more often than what your general sort of practice patients go to see their GP.
So perhaps dialysis as an example.
Yeah, or even just simple eye injections for like macular and stuff. So they're like coming back every 2-3 weeks, or sometimes 4 or 5. So they're coming multiple times a year, and they're having regular touch points with this service, and they know this service inside out. They know the people's names. They literally, like, they've taken a morning out of their life, most of them, to do this when they're supposed to be going to work. Some of them might be retired and whatever, but the next day they have things they need to go and do. So you might have 30% of these patients that have sedation for an eye injection. You have 70% that just literally have it under local anaesthetic. But 100% of these patients, and we're talking maybe 50, the next morning would get a call from the nurses. How was your experience yesterday? And all these questions that were on this sheet that had been reviewed each year, but probably had been the same questions for the last 10 years. And the nurses found it very long, tedious. It was a very big process. You had 2-3 people sometimes making these calls, all for the patients to hang up on them, ignore the call, or pick it up and say, I don't want to say anything else than I've already said, put it down, or to say everything was great, put it down, whatever. But the patients would come in and they would say, look, can't we just be sent a text that says, how was it? And we reply, or can't we just be sent a link that we fill out a form like, you do for everything else, like your NRMA and everything else. And they just sort of wanted this different process. And what I noticed was people that were asking were people that were 60 to 100, not even joking. And a lot of these people manage their diabetes with their phone in their pocket, with their sensors on their arms, and all these different things that they're touching and utilising technology day to day. So from noticing this, we spoke about it as staff, and it sort of went from the patients back up. But the patients weren't putting in feedback formally, they were doing it informally through the staff. And that's where I guess the first process problem is highlighted, that, there should be a process that's defined for everything. We did very informal surveys amongst the patients that was not really, electronic survey or anything like that, but it was a survey done amongst the staff that were there amongst a few surgical lists with these patients, and we were doing sort of a tally on the patients on what they would want. And it was literally almost higher than 80% were saying that they didn't really want that call and they would prefer any other option than to have a call the next day. But there was still 20% that did want the call, right? So it highlighted this need for this sort of patient-centered care approach where you literally care for the patients how they want to be cared for. And that promoted this change in, let's maybe create a form or a survey. And once the process was in place, the patients were actually giving us better data feedback, and we were getting a high amount of return. And also we had patients more satisfied because we were not only listening, but we were doing something about what they've said. But then I guess when you look at this problem on the other side, the other additional benefits was that we freed up a lot of nursing time because they weren't making calls, which allowed them to focus on, on all these other things.
Absolutely. 2 or 3 people, did you say, that were making the phone calls? Yep. That's quite a lot of resourcing on a daily basis.
Yep.
Of highly skilled people, probably doing a job they're not exactly enjoying if they're getting hung up on.
No, and I think that's a good point, actually, Will. So in a lot of these day surgery environments, you have a lot of highly skilled RNs that might be working as RNs or CNSs, and because these places are highly skilled and they do all this work, they often will have no auxiliary staff, but a lot more skilled other staff. So for instance, when I was an RN CNS in one of these areas, we didn't have any wardsmen at all. but the anaesthetic nurses were anaesthetic nurses and the wardsmen. And when you talk to people in other hospitals about that, they can't really fathom the idea of that because they're like, but how does this happen? It's like, but the anaesthetic nurse does it. And they're like, but how do you do this? And it's like, well, you make it work because it becomes part of your workflow. But you sometimes have a really highly skilled nurse that's making phone calls for an hour that probably has set out in their career to do something a bit different with their day, but for that hour they're making calls. So if they could turn that hour into 20 minutes because the patients can do their surveys with an electronic survey, and then that 20 minutes is high quality calls with the patients who want it, and they can go do something else. Well, it's win-win.
It's a much better outcome, absolutely. And then the benefit for the service, obviously, is that you get a more complete data collection across all visits.
But also increased staff productivity, streamlined work days, contributing to a more positive workplace atmosphere. Just there's so many side benefits that I experienced that I went, wow, this is very powerful. And if you talk about, I guess, outcomes as a whole, as we sort of wrap up this example and the whole 3 examples, it's very powerful. Like we saw outcomes that affected our patients, our service delivery, our productivity, our happiness, just every aspect of it, which obviously then helps the doctors do their work, and everything just went around. So it was just beautiful.
Well, I think on that note, Rory, I'll thank you for being on the show. It's been a really insightful conversation. I really appreciate you making the time. And those examples, it really got my heart racing a couple of times, especially the anaphylactic incident that, I guess you've got seconds and minutes to respond in those situations. So thank you very much for being on the show.
No problem at all. Thank you so much, Will. I'm glad we found some time, and I've enjoyed it immensely. So hope the listeners do too.
Just before you go, seeing as you gave AusMed such a great plug, how can people find the Aussie Nurse Educator?
Yeah, so to find Aussie Nurse Educator, started out on Instagram. You can always find me there, and I'm on all the other socials as I slowly get going there. But the main website is aussienurseeducator.com. You can always find me there, and you can contact me through the contact button or on Instagram whenever you'd like.
Wonderful. Thank you very much, Rory.
No problem at all. Thanks, Phil.
You've been listening to Outcomes, a show about uncovering the hundreds of micro-innovations that help make Australia's healthcare system one of the best in the world. This podcast is produced by AusMed, one of Australia's leading providers of educational content and software to the health, aged, disability, community and allied health sectors. To find out more, head to our website, ausmed.com.au. To make sure you don't miss an episode of Outcomes, be sure to subscribe to or follow the show in your favourite podcasting app. And while you're there, please leave us a 5-star review, as it really helps others to find the show. I'm Will Egan, and I'll see you next time for another episode of Outcomes.